Hi, everyone. I'm Dr. Safida Mokhtari, currently a neuro-oncologist at Moffitt Cancer Center. And like Dr. Irani, I have a background in neurology, but I also focus in neurologic complications of cancer and cancer treatment. Also treat brain tumor and brain metastases. I also run clinics for rare tumors at Moffitt Cancer Center, including neurocutaneous syndromes. And as part of my focus, I collaborate with Curren Foundation to increase awareness about paraneoplastic syndrome, and also through our collaboration with other scientists in Mayo Clinic, and we try to do pilot studies and projects to understand more about the condition, and hopefully we can develop better treatment for our patients that we see in our clinics. I'm going to ask some questions, I guess, as us providers. We run it many times. We get consulted for patients who have either psychiatric issues or confusion. That's probably number one reason they consult neurologists in hospitals. When would you start thinking about potentially this is something reversible or paraneoplastic in nature? When would you start questioning that, and then what kind of tests would you run at that point?
Yeah, it's difficult, isn't it? Because you never want to miss somebody, so you don't want to give blanket advice. But I think on the whole, if it's quick, if it's happened relatively quickly, and so psychiatric-wise, we often think, don't we, about NMDA receptor antibodies, which prominently have a psychiatric syndrome, usually comes on within a few days. You know, patients usually come into you maybe a week. There's been behavioural problems, there's been agitation, there maybe been hallucinations by then. So I think that tempo is number 1, 2 and 3. I think it's the most important thing of all. And then added features help you a little bit. So the psychiatric syndrome in some of these diseases is rarely very discrete. It's rarely one symptom that just persists. It's usually multiple symptoms that come. They usually cross-cut boundaries that are traditionally held together. So, for example, patients will have problems with mood and psychosis at the same time, just in a few days. And then they coexist with other neurological problems. So they will coexist with, say, confusion, as you mentioned, memory problems, maybe a movement disorder, maybe other aspects. So I think it's the complexity of the syndrome that's the key. That's the one word I'd probably use if I was forced to.
And when you kind of determine this could be paraneoplastic syndrome, then what kind of test would you initiate at that point?
Yeah, so then you think about a spinal fluid quickly, a scan of the right part of the neuroaxis, and then an EEG can be helpful as well in some patients to look for the degree of the encephalopathy.
And I wanted to ask your opinion. So we really want to save brain cells by diagnosing it earlier, and that is partly the reason why we have this initiative, is to raise awareness for patients, families, and providers. As clinicians, though, when we actually have the diagnosis, when would you decide to there are recommendations for first-line drugs such as suppressive treatments with steroids and IVIG, and then we have the second-line drugs like rituximab and Cytoxan. When would you decide that it's more appropriate to do one versus the other?
It's a difficult decision, right? And as you say, we have guidelines, but we don't have proper evidence for this field. But I think there is some consensus amongst experts, amongst clinicians who've seen lots of these patients. I think there is some consensus, which I think is always pretty reliable. So I think most patients would get steroids quickly because they're easily accessible. They rapidly cross the blood-brain barrier. They can have an effect on the central nervous system, and they also quieten down the immune response in the periphery pretty quickly. So I think that's really useful, quick to do, easy to do, and from a 3 to 5 day course, very few side effects. And then comes the question. You've bought yourself a few days to think, to get some extra information maybe, to assess risk of infection, risk of side effects, other adverse effects. And my practice would be to step up the treatment pretty quickly. So I tend not to go for IVIG at this stage. I tend to go straight to, say, cyclophosphamide. That would be my go-to at that point. That's my personal preference in most cases, but I think it's also reasonable to give IVIG. There was a little data supporting the use of IVIG in these patients. Plasma exchange, I'm always a little more skeptical about because the antibodies don't per se cause the disease, and that's thought to be the main, but not only, effect of plasma exchange. And then rituximab, similarly, because many of these diseases are thought to be T-cell mediated, I often prefer cyclophosphamide. But some of them have a clear B-cell component as well. And in that case, rituximab would be not unreasonable. Just remembering that when you've given people 2, 3, 4 different medications, their risk of infection in particular starts to step up. And sometimes that can infection risk makes me quite nervous giving them multiple drugs very quickly. So I tend to be a little more cautious with trying to use, say, 2 of those 4 rather than all 4.
Yeah, so we deal with additional complication because we treat mostly cancer patients, and a lot of their chemotherapy cancer treatment has really suppressed their immune system. So we really have to be careful when we choose one drug versus the other one. And then the other thing that you may have pointed out that a lot of these paraneoplastic syndromes that are associated with cancer, a lot of them are T-cell driven. So I think a very great point that maybe we should consider giving Cytoxan earlier without wasting more time and more complications with others. In the area of cancer, now we have immunotherapy, and now we have these patients that we particularly see after immunotherapy within weeks to months after immunotherapy or after few doses of immunotherapy. They have significant complication with neurologic syndromes that sometimes we see also with paraneoplastics, and a lot of these patients end up getting tested, and some of them have antibody positive syndromes. What are your thoughts? I know there's a lot of literature, or this is an unknown field, but what is your input in what's causing the syndrome? Is it the ones that are positive, is it due to the immunotherapy, or is that someone that had it before and immunotherapy just exacerbated their?
Yeah, good question. I think they probably had a predisposition before. Whether that was because of the tumour or not, I think remains to be answered, but probably a predisposition secondary to the tumour. And then the checkpoint inhibitors just tipped them over the edge. Now, that's not true, of course, in people with, for example, melanoma. It could be. We don't think it's true. I'm going to start that again. So that's not true in people with, for example, melanoma, where that does not associate with paraneoplastic syndromes traditionally. But you give them checkpoint inhibitors because they're very responsive to that, and they get a high rate of, or a good rate of complications at least. So I think in some it's clearly not necessarily as simple as that. But I always think that the checkpoint inhibitors cause the illness quite quickly, within 4 to 12 weeks. So
correct. That's been our experience. They don't
take 9 months. They don't take 12 months. You think of something else if it's a longer story usually.
And do you think the immunotherapy has quite an impact on patients who are predisposed to having paraneoplastic syndromes to begin with? Yeah,
for sure. Yeah, and then you get into that really difficult situation, don't you? Do you give them their checkpoint inhibitor again?
Right. Or in some cases, should we check for that beforehand?
Right. Yeah, that's very interesting. I think that would be a very interesting thing to do.
And that is a study that hopefully we can do together in collaboration with Mayo.
That'd be really exciting. I think that's right. I would predict they will have low levels of antibodies in many cases, but not all.
And it's interesting to see what changes after exposure to immunotherapy and other cancer treatments. So what does the future hold for continuing research in treating paraneoplastic syndrome?
I think the future is really exciting. So there's one area that's discovering more and more of these antibodies and giving us more and more biomarkers to diagnose patients, but also to understand the basic biology of what's going on. And that's an exponentially growing field. Over the last few years, there have been so many markers described. I think you and I would probably struggle to name many of them now because it's just so hard to keep up with that literature. At the same time, there's a field, and we're focusing on this especially, which is trying to understand what's happening with the underlying immunology, because in my view, the immunology is the most treatable aspect of this. And so if you could really characterize that and get down to what's happening in an individual patient, you could start to offer them very tailored, very precision medicines for their illness. So I think that's a very exciting area and something we're trying to study in great detail. And then there's an area, some people believe that trying to understand what's happening to the actual brain or the neuron at that level is also targetable. I personally think you'd have to combat the immune system as well as that, but I think nevertheless it is a really exciting area to go for. Could you try and prevent the T cell or the B cell or the antibody actually binding to or having an effect on the neuron? That would be a really exciting observation if people could work it out.
How can we as providers or patients or family members advance research here in the area, and any suggestions how we can all participate in this?
Yeah, it's a really good idea, and I've always felt very fortunate that I think we counted 95% of our patients in the UK were consenting to be part of our research. And that could be anything. That could be just take some blood that day. That's still a big contribution. It could be allow us to look at clinical records to understand which factors predispose them to their illness or find something new from that. And there are several examples where that's really made a difference to patient care. It could be something a bit more adventurous and perhaps a bit more invasive, where we would take samples of unusual tissues, particularly spinal fluid, but also we've been sampling patient lymph nodes as part of this and their tumours. So with all that combined, patients can make a massive difference to the next generation. I often say to my patients, you're very unlikely to impact on your care. Just research takes a little while to gestate, but I think you can always help the next generation of patients coming through. And I've always found our patients to be remarkably altruistic, and that is their major motivation for helping with the research. And I think that's really what we can encourage our patients to do as a community, to assist with these things.
That's wonderful. And hopefully through Curren Foundation, we will have resources available for patients and family members and providers to give them education how they can answer their questions and get the care right away. Anything else you would like to share with our audience?
No, I just think, I think so. I think it's a very exciting time for these diseases. There's now really good international recognition that these diseases exist. The brain can be affected by immune conditions, which there wasn't a few years ago. And certainly when I started in the field, there was still skepticism about how these antibodies could affect the brain. I think there are a very exciting transformational time in immunology, where most drugs that work in human diseases now are based on targeting the immune system in some way or the other. So it's a very exciting therapeutic time. I think there's lots of opportunities for patients, for their relatives, and for interested up-and-coming scientists and clinician scientists to get involved in this field and try to take it forward to the next level, which I think will happen very soon.
Thank you so much. This was wonderful. Greatly appreciate you.
Thank you.
Thanks.